Thank you. I appreciate you all getting up early on a Saturday morning. Actually, the topic that's listed is incorrect. What we're going to be talking about right now are late effects of head and neck cancer therapy as relates to swallowing and nutrition. And I think everybody knows that there's a big push for survivorship activities. There are a number of things that are required of us when it comes to taking care of our survivors. Of course, we all think of the importance of cancer surveillance. We think of health behavior modification. We think of health maintenance with regards to non-oncologic processes. But perhaps the most important thing that we can do for our patients is to identify and deal with the late effects of therapy. And that's what we're going to be discussing today. So what we are going to be working on is a review of the problems or the conditions that may impact on swallow function and nutrition. Before we start talking about those in detail, what I want everybody to understand is the trajectory of late effects in head and neck cancer patients. And this is a study that was recently presented at ASTRO by one of my junior faculty members. This is data from an R01. 49 patients who participated in that particular study were asked to complete the Vanderbilt Head and Neck Symptom Survey 2.0 at multiple times across their treatment trajectory. That included baseline at the end of treatment and then every 6 weeks during the recovery phase. And the purpose of this particular analysis actually was to demonstrate that this tool was responsive to symptoms over time, which it turned out that it was. But more importantly, when we looked at the data from this particular study, it became very evident that symptom recovery was not the same across all symptom subtypes, and that symptom recovery could be broken down into 3 different categories. And we categorized them as type 1, 2, and 3 based on the trajectory. So type 1 were symptoms that were most severe at the end of therapy, largely resolved and resolved quickly. Type 2 were those symptoms that were worse at the end of treatment, improved reasonably quickly for most patients, and by the time you got out to a year, only a modest percentage of patients had this problem persisting. Then we had type 3, and those were symptoms that were worse at the time of completion of therapy, but failed to resolve as quickly as we had anticipated. Indeed, a significant percentage of patients still had significant symptomatology a year out. And interestingly, that was a high percentage of the symptoms that patients report, including taste, smell, swallowing solid foods, issues with weight, issues with dentition, and xerostomia. I'm going to be presenting the data in box plots. For those of you who are not very familiar with box plots, what you get is a median line that tells you where the average patient is. You have an upper box which tells you the quartile above that, and then the highest quartile is represented here. This is the quartile below median, and then the lowest quartile. This is the minimum, the maximum, and then outliers or dots. The benefit of looking at box plots is that you can use non-parametric data, and it gives you information on skew and spread, which is really important when you're talking about symptoms, because in symptoms, median may be uninformative. So here is trajectory 1, exactly what one would anticipate for things like swallowing liquids. The red bar are the symptoms that are significantly worse when compared to baseline, that patient's baseline. And as you can see, by the time we get out to 42 weeks, very few patients have significant problems with swallowing liquids. There are a few outliers, but for the most part, this has improved. Trajectory 2, this is mucus. And you can see that mucus production remains a problem for patients 6 weeks out, and it starts declining thereafter. So by 12 weeks, we are now no longer statistically significantly different from baseline on average. But you can see that even out at 42 weeks, there are a subset of patients who have problems with mucus. Now, those problems may not be severe for the majority of them, but it's still a bit of an issue. These are the patients and the problems that we need to worry about. This is a representation of xerostomia. And as you can see, Although the problems with xerostomia are at their worst at the end of treatment, they remain problematic and significantly elevated from baseline all the way to 42 weeks. And a very high percentage of patients have significant problems with xerostomia laid out. What does this tell us? This tells us that we can't pat the patient on the back 3 months out from treatment and tell them they're fine. We need to continue to persistently identify and deal with the late symptom sequelae in these patients. So what are the late symptom sequelae? And these are the ones that we're going to be talking about, because what we're interested in is those symptoms that are associated with issues surrounding swallowing and nutrition. What I do want you to note is we will be talking about these as individual problems, but it should be recognized that these are interrelated and interconnected and sometimes cannot be separated from each other. We're going to begin by talking about the problem that all of us think about when we talk about swallowing deficits, and that is soft tissue damage. And there are two processes that can affect, when we think about soft tissue damage, most of the time we think about surgical extirpation of those structures that are necessary for normal swallow function. What we tend not to think about are the residual tissues and their functional status. And clearly, not just surgery, but radiation, particularly when combined with chemotherapy, can alter soft tissue and its functionality. And it can do so through two major mechanisms. The first mechanism by which chemo and radiation can damage soft tissue, or surgery can damage soft tissue that is residual, is lymphedema. Lymphedema was not something that was talked about 10 years ago. Now it is recognized that it is one of the major underlying mechanisms by which patients' functional deficits are manifested. This is just a simple slide of some of the work that was done by myself and my colleagues looking at internal lymphedema. And what it demonstrated is that that 2/3 of patients have internal lymphedema after completion of therapy. And for 13% of those patients, it's severe. Why should we worry about internal lymphedema? Because it correlates very heavily with a number of symptom control problems, including swallowing and nutrition. The second mechanistic cause of difficulty with swallowing is fibrosis, and I think we are all very familiar with this. And by the way, contemporary theory would be that lymphedema and fibrosis exist on a continuum. This is a depiction of a patient who has severe fibrosis secondary to combined chemoradiation therapy, and as you can see, the structures in the pharynx are acting more like a rigid tube rather than muscles that contract in a coordinated fashion to propulse the food bolus downward. Now, I'm not going to go into fibrosis in any detail. I have a whole hour-long discussion on that. What I do want to highlight are two fibrotic processes that are very important for you to screen for because they can be dealt with if they're identified early. The first is trismus. As you are all aware, there are a number of structures that are necessary for normal occlusion, including the muscles of mastication. Both radiation and surgery may damage those structures, and there are a number of sequelae of that. Deviation of the mandible, joint sounds, dislocation or locking, pain on movement, but most importantly, restriction of movement, trismus. And when that happens, patients have difficulty eating, they have impaired speaking, it becomes difficult to maintain dental care, difficult to intubate when necessary, and reduce pulmonary function. For patients receiving radiation therapy, the incidence of trismus correlates with the dose of radiation to the muscles of mastication. And there is a very steep dose-response curve. It is thought that this is due largely in the radiation population to fibrosis. The wisdom is that it begins 2 to 6 months post-treatment and is ongoing. Actually, we have data that would demonstrate that that's not the case, that it actually starts earlier. It appears that concurrent chemoradiation may increase the incidence, and it is really unclear that IMRT can alter the incidence. This also occurs in the surgical patient population. In this particular study, 89 postoperative patients. Trismus was defined as an interincisal distance of less than 35 millimeters. 31% of fully dentate patients, 40% of partially dentate patients, and 57% of edentulous patients developed trismus. For radiation patients, here's the traditional time course. This was a very well done study, and because they measured trismus quite frequently, it was only 17 patients. These were patients who received radiation only. And as you can see, the incidence of trismus over the 3, 6, and 12-month period, with most of the trismus developing between 1 and 9 months. Why do we care? We care because when patients have moderate and severe trismus, it does truly impact on their functionality. And once the interincisal distance drops to less than 24 millimeters, patients have difficulty swallowing any solid foods at all. So it behooves us to monitor, to educate patients about this, to monitor for this, and if patients start developing any decreased range of motion problems, that we intervene with aggressive exercise and stretching regimens. We have a study right now which is a randomized trial of 40 patients, 22 intervention and 20 standard of care. The intervention is the Dynasplint. We have 39 of 40 patients accrued. My poor little fellow is running around looking for the 40th patient because her life is going to be a whole heck of a lot better once that patient is enrolled. We hope that we'll be able to present that data at ASCO next year. The second major problem with fibrosis that we need to know about is proximal esophageal stricture. And this is something that we really didn't pay as much attention to when we used only radiation therapy because the incidence was relatively small. But when chemoradiation became the standard for patients with locally advanced cancers who were proceeding to who were being treated with combined modality therapy, the incidence was noted to rise. Why is it important to recognize stricture? Because it can be effectively treated with dilatation procedures. There are a number of studies out there now that show pretty much the same thing. I've just selected one. 24 patients who either had chemoradiation or surgery who developed stricture. The patients underwent endoscopic dilatation. There was a technical success in 80% of patients, and patient-reported relief of symptoms in 84%. So we can help a significant percentage of these patients. So if you have patients who have difficulty swallowing, it behooves us to make sure that they go to the speech and language pathologist. And if the speech and language pathologists are concerned that there may be a stricture, it is important that they get referred to whoever does the dilatation procedures at your institution. I think the downside to recognize is many of these patients need multiple dilatations or intermittent dilatations in order to maintain their swallow function, but nonetheless it can be night and day difference for these patients. So now let's move away from the soft tissue issues and move on to xerostomia. This is something that anybody who's taking care of head and neck cancer patients is very familiar with. Saliva is important for lubrication of oral tissues, and without saliva, there's impaired food bolus preparation, and that can lead to significant changes in diet intake and difficulty with swallowing. This is data from the VHNSS version 2.0. What you're looking at here are patients, so where it says greater than or equal to 1, which is the second to the last column on the right, that means patients with any degree of symptomatology. Greater than or equal to 4 means patients had moderate to severe symptoms. These are all survivors. This is not on treatment. This is post-treatment. And what you can see is that 58.5% of patients will say that they have moderate to severe difficulty chewing or swallowing due to dry mouth. So it is a significant problem. It also leads to radiation caries. Radiation caries develop very quickly. It can, within 2 to 3 months of completing therapy in some cases. It progresses rapidly, partly because it's difficult to reverse due to the oral environment that is not supportive to remineralization. The clinical manifestations are increased translucency of the enamel, change in color of the enamel, increased friability of the enamel with fracture, and amputation at the gum line. This is what anybody who's taking care of head and neck cancer patients has seen this. The dental caries lead to fractures and chipping, which leads to dental loss. Dental loss leads to altered intake. Altered intake leads to diet inadequacies. And this is not uncommon. This is, again, data from the VHNSS version 2.0. By the way, this is a published manuscript in head and neck about a year or two ago. Again, if you look at difficulty chewing due to teeth or dentures, moderate to severe, 24%. Teeth sensitivity to hot, cold, sweet foods, 28.8%. So this is not an uncommon problem. Mucosal sensitivity. Mucosal sensitivity is neuropathic pain that patients experience in the oral cavity and pharynx, which is described as burning. It is worsened by spiced or acid foods. It is thought to be secondary to upregulation of sodium channels and sensitization of the peripheral nociceptors by pro-inflammatory cytokines as a result of mucositis and soft tissue inflammation. It can last for protracted periods of time, and it may be lifelong. It alters food choices indefinitely. Patients will say, I can't eat hot or spicy foods anymore. I can't eat fruits because fruits burn. It does not respond well to opioids. It can respond better to agents such as lidocaine, which act on sodium channels, or things like ketamine, which is an NMDA inhibitor. Is this a major problem? It sure as heck is. If you look at late effects and you look at the patients who have greater than or equal to 4 or moderate or severe mucosal sensitivity, 58.2% will say that they're sensitive to hot, spicy, or acid foods, and 43.3% say that they have to change their food intake to a moderate to severe degree. Let's move on to taste alterations. Taste is a combination of sensory mechanisms, which will be taste, texture, temperature, smell. There are 5 basic qualities, we all know that. Umami is associated with pleasure or desirable flavor, and it most strongly correlates with quality of life. When we have taste alterations, the impact is dramatic. It reduces interest in food, it reduces or alters food intake, leading to dietary deficiencies, sometimes weight loss, and it impairs quality of life. A high percentage of patients will have decreased desire to eat, altered food choices, or decreased food intake based on taste changes. And you can see anywhere between 30 and 40% in the moderate to severe range. And lest we think this is a problem that's going to get a whole lot better for everybody, here is a depiction using box plots up to 42 weeks. And you can see that the median is close to normal. That means half of patients have some degree of taste alterations long term. And if you look at the upper quartile, those patients have symptoms in the moderate to severe range, almost a year out from therapy. How about smell? 20% of patients say that smell alters their food intake late, as a late effect, in a way that's moderate to severe. A couple of interesting little facts that I just want to present about taste and pain. This I thought was a very interesting study. 100 patients 5 years out from their head and neck treatment. So these are late survivors treated with radiation therapy. They were compared to matched controls. 43% of the patients, not the controls, reported oral pain. Very similar to the data that I've presented. 62% of patients with spontaneous pain had a metallic taste. And so what the hypothesis was that the altered taste and the oral pain are both pathophysiologically linked by underlying neural damage. And more as we are looking at late effects, we're looking at syndromal-based problems that these patients have. Interestingly, current smokers report higher spontaneous and functional oral pain as well as pain-related interference. Another really good reason to try and encourage our patients to quit smoking. And this is my favorite study. I had to put it in here. Ingestion of sweet food is associated with increased pain tolerance, and it's thought to be due to stimulation of opioid activity. I've always been an advocate for chocolate. Chocolate therapy has been one of my favorites. I have data to prove that it works. There's something else that's really important for us to think about when we think about taste. Luckily, I've had 2 cups of coffee already. But normally I wake up in the morning, and if I look at this, I start smelling, and I go, and my mouth waters. We forget about the importance of the cephalic phase of digestion and how smell and taste and sight of food cause the production of gastric enzymes that prepare the gut to digest. Our patients with feeding tubes who are stressed emotionally and physiologically have a great deal of intolerance to oral intake for a variety of reasons. And the lack of smell, lack of taste can contribute by diminishing the cephalic phase of digestion. Thick secretions. We've all seen thick secretions. They can dramatically impact on patients in a variety of ways. But this is late. This is not immediately post-treatment. 28.4 and 25.4% of patients after completion of therapy will say that secretions cause choking and gagging and swallowing difficulty. So secretions are not just a minor issue. So in total, how do these symptoms impact on nutrition? This is just a summary slide from a study that we did where we asked patients in early, mid, and late recovery to complete a 24-hour diet recall using a software package. The thing I want to, early recovery, we have a high degree of diet adaptation. We expect that. A high percentage of patients are on feeding tubes. They're coming off their feeding tubes. 80% of the patients are using supplements to maintain their weight. We expect it. Mid-recovery, 6 months in, marked improvement in oral intake, but 50% of patients are still using supplements. And I think we have to recognize that we really have to follow patients' nutritional status much more intensely post-treatment than we had recognized previously. That mid-recovery phase, when patients are transitioning from their tube and largely liquid or soft foods to more, quote, normal foods, and I use that in quotation marks because our patient's concept of normal food is not equivalent to healthy food. The patients are actually at risk for significant dietary inadequacies in mid-recovery because they stop using their supplements. When we get to late recovery, what we find is that there are persistent dietary adaptations resulting in decreased intake in specific food types, fruits, vegetables. You don't have teeth, you're not going to go chomping on a carrot or an apple. And secondly, xerostomia and dental abnormalities are strong contributing factors to the altered intake at that point. And this is the nutrient deficiencies at 1, 6, and 12 months in this cohort of patients. And as you can see, there are these are the percentage of patients at risk, As you can see, when we get 12 months out, the numbers are astoundingly scary. And much of that is due to the dietary adaptations and the lack of an appropriate diet. So patients do need to continue to follow with their dietitians periodically long-term for assessment of their swallowing and nutrient intake to make sure that their diets are adequate. So finally, creating a context for swallow and nutritional therapy recommendations. First, we have to recognize the disease states or symptoms that may impact on swallow function and or nutrition. We've just talked about some of them. We have to aggressively treat treatable symptoms and symptom control issues. And that can't be just during treatment. It has to be for the whole first year, and in those patients who have persistent problems forever as a part of an aggressive survivorship program. If treatment isn't feasible, and for some of these problems I just discussed, treatment isn't feasible, you have to establish realistic expectations with the patient. The worst thing to do, I had a consult recently, a woman who came in to see me who had typical late effects from head and neck 6 months out, and including mucosal pain. And she was told by her oncologist, well, you should not have problems like that. I think you're just drug seeking. And the patient got really angry. And she was entitled to be angry because it wasn't a problem with the patient. It was a problem with the physician failing to recognize that these late effects exist and that they dramatically impact on the patient. When the patient came to see me, we talked about the fact that the mucosal sensitivity is a problem, that we do have agents, we'll work with them, that they aren't perfect, and that she might expect this to be long-term. And she said, that's all I wanted to hear, is that it's not in my mind. We have to make sure that patients are appropriately educated about the importance of these issues on their long-term health. It is important to recognize that 18% in the Hall study, 18% of patients who survived their head and neck cancer patients died early as compared to matched controls due to non-cancer related issues which were likely related to the late effects of their therapy. And we have to make sure that our patients are referred appropriately, whether it's to speech and language pathology, whether it's to physical therapy, whether it's to our dietitians, or to our audiologists. We have to make sure that the patients get appropriately referred and that they see them and they follow through. So with that, I'm going to end.